Pleasure to introduce our next symposium. I will be co-moderating with Dr. Dobbs. We put together a symposium looking at the latest and greatest in terms of controversies, topics, as far as cervical spine technology, and questions that we often get with these topics. We put together a great slew of speakers and topics. I'd like to point out that there is one additional talk in this session from Samuel Cho, looking at different materials for the use of interbody cages as well. Our next talk is Advanced Imaging Techniques of the Cervical Spine from Dr. Michael Fehlings.
All right, so I'm not Dr. Fehlings. My name is Ali. I'm one of the neurosurgery residents at the University of Toronto. Currently doing a PhD under the supervision of Dr. Fehlings. Dr. Fehlings unfortunately could not make it to the talk today due to a family matter, so I've been asked to present his slides. So we'll be talking about advanced imaging techniques of the cervical spine. So before we start, I also want to acknowledge Dr. Alan Martin at UC Davis, whose research this talk is largely based off. So we have no commercial disclosures. So as a background, imaging, while relatively new to medicine, is an essential part of spine surgery. Research on advanced imaging tend to be focused on non-traumatic spinal cord injury, so degenerative cervical myelopathy, as opposed to traumatic spinal cord injury. This is mainly for practical reasons because there are further uses for advanced imaging for degenerative cervical myelopathy and prognostication. And oftentimes with acute cervical injuries, instrumentation is done acutely and that alters some of the advanced techniques that we use. So the main rationale for advanced imaging modalities is to act as a biomarker of the microstructural integrity of the spinal cord. By doing so, imaging can address several knowledge gaps in the field, including the ability for earlier diagnosis, improved prognostication, and the ability for longitudinal monitoring for deterioration, as is the case with mild myelopathy. So to demonstrate the role that advanced imaging can play, I will use this example. So we have two conventional MRIs here. So can anyone tell which one is a patient with an MGOA 16 versus which one is for someone with an MGOA 11? I think most, without any other information, would guess that image A, so the one to my left, represents the more severe clinical myelopathy. But in reality, the image on the left, so image A, represents milder clinical disease. So this highlights the need for other biomarkers in assessing cervical spine disease. So current conventional imaging modalities are not granular enough to outline the complex microstructural anatomy of the spinal cord. So I will be going through each of the key modalities and highlighting some of the emerging advances that allow us to identify some of the granular structures. So to start off, the role of radiographs is limited in spine imaging research. This is mainly due to the fact that X-rays and CTs cannot visualize neural and soft tissues to the same extent as other approaches. There is, however, some ongoing research on the utility of flexion extension CTs and intraoperative radiographs for navigation. Moving on to ultrasound, there are some new promising approaches. A lot of spine pathologies are characterized by vascular disruption, which can be visualized with very high resolution ultrasound. Images obtained in the slides below are from in vivo experiments demonstrating the granularity that can be obtained with high resolution ultrasound. We can also clearly see areas of spinal cord damage early on through vascular disruption that is seen in high resolution Doppler images of the injured cord. The utility for this approach will be mainly with intraoperative imaging. And one of the main limitations with high-resolution ultrasound techniques is with the need for complete stability of the instruments and the cord during the imaging acquisition in order to obtain the high-resolution images that we see here. This has been done in animal experiments with these complex apparatuses. However, this has yet to be translated to clinical research or clinical practice. So moving on to conventional MRI, this is the most commonly studied modality. The main research on conventional MRIs is on identifying clinical predictors of outcomes. So in the context of DCM, there has been a lot of work done to determine clinical significance of signal change. We know that T2 signal change in isolation is not predictive of clinical outcomes, but we do know that multiple areas of T2 hyperintensity and T1 hypointensity of the core are indicative of increased impairment when compared to single areas of T2 hyperintensity. And again, this is all in the context of DCM. So in SCI research, there has been work showing that increased tissue bridges are predictive of improved clinical recovery. So tissue bridges are essentially represent areas of healthy core surrounding the hyperintense cystic cavity. So moving on to some of the newer quantitative approaches of MRI. So the difference here from conventional MRIs is that specific physical parameters are isolated and measured to give further insights into the microstructural integrity of the cord. So these approaches are more complex as they often require specialized software and the need for longer acquisition time with manual analysis of the measurements. So starting off, there's diffusion tensor imaging, or DTI. This is similar to DWI, but this modality also captures the direction of the water diffusion as opposed to just the magnitude that we see with DWI. So this allows to better delineate the microstructural features of the cord, and this is also used for tractography of the white matter tracts. So some of the baseline DTI outcomes have been shown to be predictive of motor outcomes in small clinical studies of DCM and also SCI. So the next approach I will discuss is myelin imaging. With this approach, the magnetization transfer properties of the tissue are used to indirectly measure myelin integrity. So this has been mainly used for MS research or demyelinating disorders, but several studies have shown utility of myelin imaging as a biomarker for DCM. And I have cited a paper here by Palawal, which showed the ability for myelin imaging to prognosticate neurological recovery after surgery for DCM. So next we have T2 star-weighted imaging. So in this approach, the gray white matter contrast at different levels is measured and compared. So differences in measurements can reflect demyelination, gliosis, and decreased perfusion to the cord. This is also a direct measure of cord atrophy. So T2 star-weighted imaging has been associated with greater degree of neurological impairment and can hence be used as a biomarker. So moving on from quantitative MRIs, we have functional MRIs. So in functional MRIs, neural activity is estimated by detecting changes in blood flow in response to a specific stimulus, either motor stimulus or a sensory stimulus. So this is mainly used in brain research, so brain circuitry research. In the context of spine, the current research on fMRI is mainly in establishing what the normal baseline is. But it's also interesting to point out that through MRI and fMRI studies, spinal cord compression has been associated with changes in the brain. Specifically, studies have shown white matter damage, gray matter volume loss, and functional adaptive changes in sensory motor cortex with patients that have DCM. So it must be pointed that all these modalities that I just talked about cannot just be used in isolation, and there's a need for the development of multimodal assessment, which uses these techniques as an adjunct to conventional MRIs and clinical assessment as a biomarker. So here's an example of what that looks like. So this will be like a multimodal assessment approach that uses some of these quantitative MRI measurements as an adjunct to conventional MRI to identify patients who have a progression of myelopathy. And this is based on Alan Martin's work at UC Davis. So the potential applications for these multimodal assessments is to localize pathologies, including areas of pain generators. We can also monitor for deterioration, as I discussed. It can be used for prognostication and also for clinical trials. There's a critical need for improved endpoints in clinical spinal cord injury research, and imaging biomarkers could perhaps provide some avenues for potential study endpoints. So in conclusion, there have been significant advancements in spinal imaging research, particularly with high-frequency ultrasounds and quantitative MRI techniques. There are several imaging biomarkers isolated, and we currently need to better define what the role of these are in clinical practice. So prior to widespread adoption of any of these approaches, further work is required for clinical validation and automated analysis. Thank you very much.
My name is Mihara from Yokohama, Japan. My question goes to imaging technologies. So even using the DTI or new MRI, so they are using the static view. But I think the mobility of the neural element itself is important to evaluate the future of the cervical spinal disorder. How do you think about such motion analysis of the neural elements?
No, thanks for that question. That's an excellent question. That's another avenue where there's like a lot of emerging research that's being done with flexion extension, as I mentioned, CT scans as well as MRIs. But I think at this point, they're not, at least there are no guidelines on exactly how to interpret all of these images, but I think that's another avenue for research moving forward.
Great. I want to thank all the speakers for a great session. Thank you.